If I tell you it's high yield, will you watch? The cerebral vascular anatomy and the Circle of Willis can be a little bit overwhelming, so let's start simple. 2 carotids, 2 verts or vertebral arteries come together to make 1 basilar. And that's the whole blood supply to the brain. Really, it's just 4 vessels, your 2 carotids and your 2 verts. Side note, it is perfectly normal for someone to have a dominant and a non-dominant vert. So when you look at imaging, one of the vertebral arteries can be really big and one can be really small. And that's a whole nother discussion about to see if it's pathologic or not. Okay, first up, anterior circulation. We have our 2 carotids. They terminate by splitting into 2 vessels, your anterior cerebral artery and your middle cerebral artery. And prior to the branching point, they give off the ophthalmic artery. And so the high yield key point for the ophthalmic artery is that this can pretty much cause a stroke of the eye. Amaurosis fugax, which is a curtain-like vision deficit, is caused by a blood clot to the ophthalmic artery from carotid disease. So if someone has that, you need to treat that carotid as symptomatic. The 2 ACAs come off the ICA. They're connected by the ACOM. They supply the medial portions of the frontal and parietal lobes. So if you remember your homunculus, that is primarily the leg. So if you see someone with leg weakness greater than arm and face, you need to be thinking ACA, as well as it can cause something called abulia, which is a blunted, slow to respond, apathetic personality, mainly because it's hitting the frontal lobes. In your actual brain, they kind of go out and then come back. They travel together. The key note about the anterior circulation is that the whole point of the Circle of Willis is that blood flow is redundant. In fact, I've seen a person with a completely occluded ICA that had 0 symptoms. MRI was negative for any strokes simply because of the anterior communicating artery. So say this ICA was cut off, so you have no blood supply to your MCA or ACA over here. Well, this ICA pumps the blood, it goes to the ACA, and then it crosses the ACOM and supplies blood to the other half of the brain. The key thing to remember about the ACOM is that this is where there is most likely to be an aneurysm within the whole circle. Okay, so ACA pattern recognition, leg greater than arm or face, think ACA over MCA. Worst headache of my life, think ACOM aneurysm rupture, subarachnoid hemorrhage. Blunted personality or affect, think ACA. Next up, MCA. This is the big one. This is probably where most strokes happen. It also supplies probably the most portion of your brain as well. The MCA supplies the lateral, frontal, parietal, as well as part of your temporal lobes. Face and arm are heavily represented with MCA strokes. It's very common for someone to present with slurred speech because they're going to have face droop, contralateral face droop, and arm weakness. And side note, MCA strokes typically, if it's big enough, patients will need a PEG or feeding tube because of the face and neck muscle weakness. With the MCA strokes, you get cortical signs. If it's in your dominant hemisphere, typically the left, you get aphasia. If it involves the superior division of the MCA, you get Broca's aphasia, which is expressive. You're not able to get your words out. However, you're able to follow commands. So if you tell somebody to show me 2 fingers, they're able to show you 2 fingers. But if you're able to say, how many fingers am I holding up? They can't tell you. The inferior division typically gives you Wernicke's aphasia, which is receptive. So they're able to express themselves like I have head pain, stuff like that. However, they're not able to follow simple commands such as show me a thumbs up. If your MCA stroke is in your non-dominant hemisphere, typically the right, you get neglect and so you have right-sided MCA stroke, you're gonna have left-sided neglect. The big neglect test is you just take someone's left arm, hold it in front of their face and say whose hand it is. If they don't recognize their hand, that's how you categorize it as serious neglect. Okay, if that wasn't enough for the MCA vessels, they also give off the lenticular striate vessels, which supply your basal ganglia and your internal capsules, which cause lacunar infarcts. The key association with lacunar infarcts is hypertension, but really diabetes and cholesterol also play factors as well. Okay, big picture pattern recognition. Face, arm, but leg relatively spared, think MCA. Face, arm, leg, purely motor, think lacunar from the MCA. Patient comes in, face, arm weakness, not able to say anything but able to follow commands, think superior division, Broca's expressive aphasia. Patient comes in, face, arm weakness, but not able to follow commands but able to say, I feel weak, think inferior division, Wernicke receptive aphasia. Patient comes in, face, arm weakness, You should ask them whose hand it is. They say they don't know. Think MCA, think non-dominant parietal infarct, probably right MCA. All right, now let's transition to the posterior circulation. The big connector piece from the anterior to the posterior circulation is our posterior communicating artery. They run from the ICA, MCA down to the PCA, and they can provide collateral circulation, so they can allow your posterior circulation to help if there's an anterior clot and vice versa. Okay, the key piece of information to know and that's high yield for the PCoM is a cranial nerve 3 palsy, because the ocular motor nerve runs right next to the artery. So you get a blown pupil because the parasympathetic fibers are on the outside of the pupil versus a diabetic ischemic cranial nerve 3 palsy, in which the pupil will be spared, as is primarily the sympathetic fibers on the inside that are involved. With the ocular motor nerve palsy, you will get ptosis, drooping of the eye will be down and out, and then a blown pupil. Do a quick timeout break. You know, I hate to do this, but go ahead and, if you don't mind, giving me a subscribe, because I'm really trying to grow my channel. Continuing our trek down into the posterior circulation, we have our basilar artery. Our basilar artery gives off our 2 PCAs, which are our posterior cerebral arteries. The P1, the 1 refers to the branch of or the part of the blood vessel. The P1 is before the PCoM joins, and then afterwards is the P2. That's high yield because if there's a clot here, this is a thrombectomy candidate. If there's a clot here, probably not. The thing to know about your PCAs is your PCA supplies your occipital lobe, so it controls vision. In addition to vision, it also supplies your medial temporal lobe, hippocampus, and thalamus. So if you have, remember, a pure sensory is a posterior circulation stroke. Thalamus, pure sensory strokes, posterior circulation. The key thing to remember also for PCA strokes involving the occipital lobe is a contralateral homogeneous hemianopia. And I always stutter over that, so forget about it. What that means is if you have a right-sided PCA stroke, your left visual field in both eyes will be out. So your medial right eye and your lateral left eye, if it's a right PCA stroke. But with this, remember, it is classically macula sparing, because the macular pole also gets contralateral supply from the MCA. Also with PCA strokes, I know I'm just keep going. With thalamic strokes, the pure sensory, you can get thalamic pain syndrome, so someone can present with just pain out of proportion, as well as some sensory deficits. And lastly, one of the craziest syndromes in neurology, Anton syndrome, which is where you knock out both of your PCAs, so you're cortically blind. Your eyes still can see and perceive the world. Pupils are reactive. However, when it goes to your visual processing center, there's nothing there. So you're effectively blind even though you can see, and your body and your mind will just hallucinate things. So you will, the patient will come in, they'll say, you're wearing a red jacket, they see you, they're talking to you like they see what's going on, but they have no idea, and they can't see a single thing. And they have no idea they can't see a single thing. That's the key differentiator, is they have no idea. They think they see, but they are not seeing. Okay, key breakdowns. Vision loss, minimal weakness, think PCA, occipital lobe. Contralateral field cuts, macula sparing, think PCA infarct. Patient is blind but denies that they're blind, think bilateral PCA infarct, probably localizes to the basilar. Okay, continuing our trek down, off the basilar itself, there's a couple important arteries. First, we have our SCA, or our superior cerebellar artery. We have our pontine perforators, and then we have our anterior inferior cerebellar artery, ACoA. The key thing to know about your anterior inferior cerebellar artery is it supplies the lateral pons, so you can get a facial palsy as well as ear problems, hearing, as well as it causes same-side ataxia and a Horner syndrome. But the key thing to remember here is if there is hearing loss and facial weakness, think AICA. SCA is a little bit less high yield. The big thing to know is ataxia and dysarthria, plus or minus pain and temperature loss. So to recap, same side face and hearing with contralateral sensory symptoms, think lateral pons, anterior inferior cerebellar artery. Same side ataxia as well as dysarthria, plus contralateral pain and temp, think superior cerebellar artery. Okay, lastly, the key one to know from the basilar artery is the pontine perforators. You can just think of this just in general with the basilar, kind of interchangeable. But these will cause locked-in syndrome, just massive pons stroke, as well as affect the, is now as well as affect the now called ascending reticular activating system, which is kind of your body's arousal mechanism. So people that have large pons strokes from their pontine perforators from a basilar thrombus will have decreased levels of consciousness, which, side note, is why it's hard to stent the basilar if there's a thrombus or stenosis or whatever is in there, because the meshings of the actual stent will block off these perforators because they're so small, and just the stent itself will cause infarcts by blocking off these arteries. So basilar stents, typically not the option you want to go with. Moving on down off the vertebral arteries is your posterior inferior cerebellar artery, PCoA. The key thing to know here is Wallenberg syndrome or lateral medullary syndrome. Wallenberg syndrome and lateral medullary syndrome are super high yield. It's really a case of what does it not hit. It hits the trigeminal nucleus of the face, which means same side face, pain and temperature loss. Spinothalamic tract in the spinal cord, which means contralateral body, pain and temperature loss. Cerebellar peduncle, which means ipsilateral ataxia or dysmetria. Your nucleus ambiguous, which means dysphagia and dysarthria. Plus or minus a Horner syndrome, but relatively spares the corticospinal tract, so the key absence is there's usually minimal weakness. The key thing to distinguish lateral medullary syndrome is from medial medullary syndrome, which is from your ASA, which is your anterior spinal artery. The big thing here, hits the corticospinal tract, so weakness is the big finding. Hits your medial lemniscus, so proprioception and vibration, contralateral weakness, and then cranial nerve 12, ipsilateral tongue weakness, tongue towards the lesion. Cross sensory findings: face, loss of pain and temp, body, loss of pain and temp, plus dysarthria, dysphagia, or dysphonia. Think lateral medullary syndrome, PCoA. Contralateral weakness, cranial nerve 12 involvement, think medial medullary syndrome. And key point, cross findings anywhere, you should think brainstem. That's like the localization tip. Okay, to recap, we have our anterior circulation, our two carotids. We have our posterior circulation, our two vertebrals, which come together to form the basilar. Off of the ICAs, we get our MCA, our ACAs, our left and right are connected by our ACOM. We got to worry about aneurysm rupture. And our anterior and posterior circulation are connected via our PCoMs. Our PCoMs, you got to worry about a blown pupil. PCA, think vision cortex. MCA, think arm and face. ACA, think leg and abulia. MCA for cortical, think aphasia, dominant hemisphere, neglect, non-dominant hemisphere. Remember, off of your carotid, gives your ophthalmic artery, so think vision loss, complete vision loss, one eye, could be a stroke of the eye, think carotid, anterior circulation. Remember, pure sensory strokes are supplied by your posterior circulation, so thalamic, pure sensory, thalamic pain syndrome. Remember the key difference between lateral medullary syndrome and medial medullary syndrome. Medial medullary syndrome involves weakness in cranial nerve 12 and vibration and proprioception, where lateral medullary syndrome spares weakness, however, has contralateral pain and temp, as well as ataxia, and usually almost always involves the nucleus ambiguous, so you have dysphagia, hoarseness or dysphonia, and dysarthria, the 3 Ds. Hopefully you can read my handwriting, because this took a while. And I think honestly this covers most of the high yield stuff regarding your cerebral vasculature. Let me know what I missed. Let me know what you want me to do next. Go ahead and give me a subscribe. What have I left out?